Okay guys, so in this video I am going to cover sympathetic ophthalmitis. Now it is a kind of bilateral non-suppurative granulomatous panuveitis. Yes, panuveitis. Don't confuse, my dear friends, panuveitis with that of panophthalmitis. What is difference between panuveitis and panophthalmitis? You know, there are three parts of the uvea. Anteriorly we have got iris, then we have got ciliary body, then we have got choroid. Ciliary body is further divided into two parts. The anterior part is pars plicata, the posterior part is pars plana. If there is involvement of all the parts of the uvea, which is iris, ciliary body and choroid, you call it as panuveitis. But if there is involvement of all the layers, all the coats of eyeball, which is retina, choroid, sclera, you call it as panophthalmitis. But mind you, this uveitis is non-suppurative. Now what is the purpose of a beautiful image of chisel and hammer? So the most common mode of injury in sympathetic ophthalmitis is chisel and hammer injury, and there was also one important PYQ which is there, and that is which intraocular foreign body is the most common to enter into the eye. So most common intraocular IOFB's intraocular foreign body to enter into the eye is iron, but the most toxic intraocular foreign body to enter into the eye is copper. These are all your previous year foreign medical graduate questions. Mind you, foreign medical graduates, if you are seeing this video now, in case of chisel and hammer injury, which part goes into the eye? Most of you will think that it is a part of the chisel, but no, not at all. NAO, not at all. It is actually the part of the hammer which goes into the eye. This is also your PYQ, boys and girls. Now I want to give you another PYQ for FMG students. If there is intraocular foreign body, which is the investigation of choice, you will go on for NCCT. It is IOC. You will not go on for MRI. I know marking MRI may appear very luring to you. Yes, but no, if there is metallic foreign body and you go on for MRI, so the metallic foreign body will rotate, it will move intensely inside the eye, leading to damage to intraocular structure. So MRI is contraindicated in case of metallic foreign body. But the investigation of choice remains NCCT. Okay, now what happens in sympathetic ophthalmitis? Now you need to understand, you must have read about the dangerous area of face in anatomy, of course. So there is upper lip region, hai na? So any infection in this region will enter into the cavernous sinus. Yes, similarly we have got dangerous area of eye, and boys and girls, that dangerous area of eye is your ciliary body. In case there is any injury, now injury can be of two types, means foreign body entering into the eye can be of two types. One is your penetrating injury, another is your perforating injury. What is the difference? Penetrating is if there is only entry point, perforating is there is entry point as well as exit point. So which is more dangerous? Perforating is more dangerous. Now if there is any intraocular foreign body that has entered into the eye and it hits the ciliary body, now ciliary body has got one beautiful antigen, which is a part of uvea, so you can call it as uveal antigen. But the name of this antigen, your previous year question, the name of this antigen is retina S antigen. Yes, so when there is a trauma, so there is this antigen which gets spilled into the blood, but there is blood uveal barrier which does not allow this antigen to go into the blood in normal persons. But when there is trauma to the ciliary body, so there is rupturing of the blood uveal barrier leading to spillage of this antigen into the blood. But since this antigen has never been exposed to the bloodstream of the patient ever before, so the body of the patient is going to take this antigen as a foreign body, and the body will start the production of antibodies against this antigen on a grand scale. Now, due to trauma in one eye, it has already got damaged, but the antibodies which are formed against the uveal antigen, retina S antigen, which was present in this eye, now the antibodies will keep on circulating in the body. But mind you, you have got one eye or two eyes, you have got two eyes, but there is same antigen which is present in the other eye as well, as a result of which this antibody which is circulating in the body, it will pass through blood uveal barrier and may land up in the uvea, in the ciliary body of the other eye, leading to damage to the other eye as well. So primary damage due to trauma, secondary damage due to antigen antibody reaction. This is a very, very important mechanism that you all should know. Now, how come the name is sympathetic ophthalmitis? So one eye is damaged in sympathy to the other eye. The normal eye self damages itself, but now it is not about self damage, it is about the formation of antibodies which leads to damage. Yes, now I am going to tell you all the important points which are associated with this. Now, what is the most dangerous period? Of course, the most dangerous period will be the minimum period in which the antibodies are formed. So boys and girls, it is 2 weeks to 2 months. Yes, this is the most dangerous. Some books mention it to be 2 weeks to 3 months, but 2 weeks to 2 months, this is your previous year question. Okay, this is most dangerous period. All right, now sympathetic ophthalmitis has the formation of Dehlen-Fook nodules. Now I told you in the very beginning that it is non-suppurative bilateral granulomatous panuveitis, and whenever we talk of granuloma, there must be some antigen, and you could recall that there is granuloma of tuberculosis. Yes, can you tell me what consists the granuloma of tuberculosis? Of course, there's Mycobacterium tuberculosis antigen surrounded by which cells? Epithelioid cells, macrophages. Similarly here which is the inciting antigen? It is the uveal pigment which has which antigen? Retina S antigen. So Dehlen-Fook nodules, they are uveal pigment which is surrounded by epithelioid cells and macrophages. The same that you do. I'm just trying to connect the Mycobacterium tuberculosis granuloma with sympathetic ophthalmitis, which is granulomatous panuveitis. Okay, so uveal pigment surrounded by epithelioid cells and macrophages. Now these Dehlen-Fook nodules are present at sub-RPE region. It is present between retinal pigment epithelium and Bruch membrane. You know na. So there is a retina. So retina has got 10 layers. Inner 9 is neurosensory layer, then outer 10th is retinal pigment epithelium, then we have got choroid, but between the RP and choroid there is another layer which is Bruch membrane. Then after choroid we have got sclera, then after sclera, can you tell me which is the structure? Most of you will say, sir, conjunctiva. No, my dear friend, out of sclera there is no conjunctiva, there is Tenon's capsule, then there is conjunctiva. Yes, okay, and these are your Dehlen-Fook nodules. Yes, and they are present in the posterior segment. Yes, because they are at the sub-RPE region. Now I also want you to know that the chances of sympathetic ophthalmitis in any injury is just 0.2 to 0.3%. Okay, this concept, this single line I'm going to use while telling you the treatment of sympathetic ophthalmitis. Now, what will be the earliest sign? So what was happening in sympathetic ophthalmitis? So there was damage to ciliary body, है ना, ciliary body, uveal antigen, retina S antigen. So earliest sign, of course, because of inflammation, antigen antibody reaction, there will be spillage of the cells, the proteins, the exudates, and which will lead to formation of retrolental flare. Proteins cause flare, and retrolental means behind the lens. So in posterior segment there will be release of inflammatory exudates, which you will see. That is the early sign. But earliest symptom, since there is involvement of the ciliary body helps in accommodation, so earliest symptom will be loss of accommodation. Patient will not be able to see near objects quite clearly. Now, if there is damage to ciliary body, of course it has got ciliary muscle which help in accommodation. Not to forget, there is a region which is pars plicata on the ciliary body, which is a part of it. Pars plicata helps in formation of aqueous humor. Which cells of pars plicata? Your previous year question. Non-pigmented epithelial cells of pars plicata, they lead to formation of aqueous humor, which is released in the posterior chamber. Through the pupil it will come into the anterior chamber. Through the trabecular meshwork it will go into canal or Schlemm, then episcleral venous plexus, then it will go into the cavernous sinus. So most dangerous sign is when there is hypotony because of damage to ciliary body. Now there is complete shutdown of the formation of aqueous humor, boys and girls. Mind you, hypotony is when the IOP is less than equal to 7 millimeter of mercury. Okay, there are other signs as well. Another sign that you have is that there are numerous cells in the anterior chamber, of course, because we are talking of panuveitis. So there is exudates in the posterior segment, there will be cells in the anterior chamber as well. All right, so this is about the signs and clinical features of sympathetic ophthalmitis, which are important for you. Now, based on the mode of injury, I am going to tell you the treatment. So this question has been asked many times, mind you. So one is when the damaged eye is PL negative, that means there is no perception of light, but other eye is 6/6, and the patient has come to you as soon as possible. So the patient has come to you, say 5 hours, 6 hours, maybe 12 hours after the injury, and you examine the patient. The other eye is normal, of course, but the damaged eye is light perception which is negative. So, but you know, there is chance of sympathetic ophthalmitis by 0.2 to 0.3%, but one eye is already gone. There is no point of saving the eye. Would you take risk of even 0.2 to 0.3% that it may cause sympathetic ophthalmitis? If it causes sympathetic ophthalmitis, the patient will go blind. The patient's one eye is lost due to trauma, but the other eye, which is normal right now, can go into sympathetic ophthalmitis and it can go blind. So in that case, you will not take risk, although it is minimal. So you will go for removal of the damaged eye, the eye which has got injury, which is PL negative, enucleation. Don't go for enucleation of sound eye, otherwise the patient, you will make the patient go blind, hai na? Enucleation of injured eye. Yes. Okay, now there is second criteria. When injured eye is having a vision of 6/60, which is a good vision, and other eye is normal, what will you do? Are you going to enucleate this eye? No. If it is the case, then any patient which will be coming to you with the slightest of injury will keep on removing the eyes. आप तो पूरे community की आंखें निकाल दोगे ऐसे पकड़ के, right? So what you are going to do? You are just going to perform a primary रिपेयर सर्जरी. आप सिर्फ जो ट्रॉमा होगा, जो परफोरेशन होगी, उसको आप रिपेयर करेंगे. इंट्राविट्रियल इंजेक्शंस दे देंगे विच विल बी एंटीबायोटिक्स टू प्रिवेंट एंडोप्थेल्माइटिस. प्राइमरी रिपेयर करेंगे एंड यू विल कीप द पेशेंट ऑन फॉलो अप. फॉलो अप पे पेशेंट को रखेंगे, बिकॉज जस्ट फॉर 0.2 to 0.3% ऑफ चांस यू कैन नॉट रिमूव द आई विथ 6/60, which is a good vision. Now there is the third criteria. Now the patient has come to you late, say after 2 weeks or 3 weeks, but I told you dangerous period is 2 weeks to 2 months. Some books mention even 3 months. So one eye is PL negative. So one eye is PL negative. So other eye has developed the signs and symptoms of sympathetic ophthalmitis. What will you do? You have read it before. Once the antibodies are formed in the body, they are going to remain for the rest of the life. Now at this point, even if you go on for enucleation, it will not help because the antibodies are already formed. So why to give another trauma of removing the इंजर्ड आई टू द पेशेंट? तो आप एक और ट्रॉमा क्यों दोगे पेशेंट को? यार पेशेंट तो ऑलरेडी एक आंख लूज कर चुका है, बट दूसरी आंख में पेशेंट के सिंपैथेटिक ऑप्थेल्माइटिस के साइंस एंड सिम्टम्स आपको नजर आ रहे हैं. तो व्हाट यू आर गोइंग टू डू? यू आर गोइंग टू गिव हाई डोज स्टीरॉइड्स. यस, आप हाई डोज स्टीरॉइड्स देके कंट्रोल करोगे इन्फ्लेमेशन को. यस, सो आई गेव यू 3 क्राइटेरिया. First criteria, you can go for enucleation. Second is you just go for primary repair and keep the patient on follow-up. If on follow-up you can see that there are signs and symptoms of sympathetic ophthalmitis, तो फिर आप हाई डोज स्टीरॉइड्स पेशेंट के स्टार्ट कर देंगे. इन थर्ड सिनेरियो, इवन इफ वन आई इज PL नेगेटिव बट द पेशेंट हैज कम टू यू विद द साइंस एंड सिम्टम्स ऑफ sympathetic ophthalmitis in the sound eye, in the non-injured eye, in the other eye, you will only give high dose steroids. So boys and girls, this is all about sympathetic ophthalmitis. I hope you enjoyed the video. Let me know how you liked it and I'll be coming up with more such videos. बहुत बहुत धन्यवाद आपका. Thank you.